Yes, please go ahead. Thank you.
Good morning, everyone. I'm Sandy Shatil from the Division of Hematology Oncology, and it's my pleasure to present you the speaker for the Ranney Lecture this morning. The Ranney Lecture is an annual event in the Division of Hematology Oncology in the Department of Medicine, during which a prominent hematology expert is asked to deliver a seminar on a subject of medical importance to specialists, generalists, and students alike. This year, the Ranney Lecture will be given by Professor Douglas Cines from the University of Pennsylvania. I would like to begin with a few words about Dr. Helen Ranney, a physician scientist and a giant in the field of hematology and medicine. Helen was born in 1920 in Summerhill, New York, where her parents ran a dairy farm. She attended a one-room school as a child and was a graduate of Barnard College and the Columbia University College of Physicians and Surgeons, a medical school that seriously erred by rejecting her on her first attempt at admission. During subsequent faculty positions at Columbia, Einstein, and SUNY Buffalo, she developed an international reputation for her research related to hemoglobinopathies, eventually leading to her election to the National Academy of Sciences. Most importantly for us at UCSD, she was the first female chair of the Department of Medicine, beginning in 1973, an inspiring mentor to all and a go-to person for difficult hematology and medicine cases. I came to know Helen personally after my move to San Diego in 1994, and my semi-monthly lunches with her and Ernie Beutler from Scripps, another giant in the field of hematology, were lessons in intellect, warmth, wit, and perseverance. Helen passed away in 2010 at the age of 90. Today's Ranney Lecture will be presented by Dr. Douglas Cines. Doug is currently a professor of medicine and pathology and laboratory medicine at the University of Pennsylvania. He received his MD from NYU in the mid-1970s and trained in medicine at Duke and hematology oncology at Penn. I was a young faculty member at Penn in those days, and I remember Doug as a fellow teaching me, instead of me teaching him, many lessons pertaining to hematology and immunology. Over time, Doug has become a leading international expert in platelet biology and immunology, and I continue to consult him periodically for help on difficult cases. He's a member of the ASCI and the Association of American Physicians, a member of many guideline panels for immune thrombocytopenia and heparin-induced thrombotic thrombocytopenia, formerly known as HIT, now referred to as HITT. And he's developed a unique perspective on current hematologic problems related to the COVID-19 epidemic, in particular, vaccine-induced thrombotic thrombocytopenia, known as VITT. Therefore, it is an enormous pleasure for me to introduce Dr. Cines to you today to present his Ranney Lecture entitled, First HITT, Now VITT, What's Going On with Platelet Factor 4? Doug, thank you very much.
So good morning. Can you see my screen? Okay.
Yes.
Okay, great. Well, thank you very much for the invitation to give this important lecture. And Sandy, thank you for the kind introduction. So the title of my talk, as Sandy said, is First HITT, Now VITT, What's Wrong with Platelet Factor 4? I have nothing to disclose with respect to this talk. And I want to start out with a couple of case presentations. So this is a 58-year-old male who received unfractionated heparin during his catheterization and bypass surgery. And then 7 days post-op, he developed what you can see as an ischemic foot with a platelet count of 64,000. As part of his workup, a test was done, which we'll talk about, called the platelet factor 4 ELISA, looking for antibodies to platelet factor 4 polyanion complexes, and the test was strongly positive. The second patient is a 62-year-old healthy female who 10 days earlier received a J&J vaccination against COVID. And then she developed headache and somnolence and was found to have a platelet count of 34,000. And imaging showed multiple small thrombi in the cortical veins and in the sagittal thrombosis. And she too, as part of her workup, had this test called the PF4 ELISA, and she too had a positive optical density, a positive result based on optical density. So I have two objectives, two questions. What are two serious syndromes associated with antibodies to a single normal endogenous host protein called platelet factor 4? And my second question is, what are two different syndromes associated with antibodies to platelet factor 4, one initiated by heparin and one initiated by a vaccination? So let me start talking a little bit about HIT first. This slide shows the incidence of HIT between 2009 and 2013, and I think it's true now. There's about 20,000 cases a year. So one would have thought that this disease would be long gone by now with the advent of so many alternative anticoagulants, but it's not. And the reason it's not is that unfractionated heparin continues to be the go-to anticoagulant for high-intensity anticoagulation during bypass surgery. And I also wonder, I'm going to come back to this, I just wonder whether or not, what the consequences are of us giving a universal repetitive heparin exposure for good reason, thromboprophylaxis. So this disease is still with us. The most important clue to the diagnosis of HIT is shown on this slide, which is the incidence on the ordinate and the days of heparin exposure on the abscissa. And so in a heparin naive individual, this disease develops about a week after heparin exposure. If you've had previous exposure, and if you still have circulating antibodies, then the initial treatment, the initial exposure can be enough to initiate the process. And then there's this very unusual syndrome that's not very well worked out, that's sort of rare, in which individuals may not have been recognized to have this disease at the time of being discharged. And then they come back a week later with a thrombosis and they get heparin. And of course, that would reinitiate the process. So this timing is very critical to understanding what's going on here. And there are a couple of clinical implications. For example, in a heparin-naive individual who develops thrombocytopenia on the day or the day after heparin administration, that's not consistent with HIT. On the other hand, patients have had HIT superimposed on another earlier cause of thrombocytopenia. So a patient after bypass can have a low platelet count because of the procedure. The platelet count comes back up or never comes back up and then drops down a week later. And so HIT can be superimposed on another cause of thrombocytopenia. And then there's this autoimmune thing where there's autoimmune disease where there's no heparin exposure and you seem to develop the same syndrome. And I'm going to come back to that when I talk about VITT. So the clinical manifestations are thrombocytopenia, which is typically moderate. And in fact, you really don't have to be thrombocytopenic to meet criteria. I mean, one definition of risk is a 50% fall in platelet count that's unexplained, or any new thromboembolic event in proper temporal relationship to heparin exposure. And the reason is because the platelet count can fall in the next 12 to 24 hours. When thrombosis happens, which is frequent, it's usually venous, DVTs and PEs, but large and small vessel arterial occlusion can happen as well. And then there are rare presentations with microvascular thrombosis, skin necrosis, ARDS, and anaphylaxis. So I want to switch now to talk a while about the pathophysiology. So these antibodies are heparin induced, but the antibodies are not to heparin. They're to a protein called platelet factor 4 that binds heparin. So what is platelet factor 4? It's a small protein that's stored in the alpha granules of platelets. It's among the most abundant proteins released when platelets are activated. The physiological function is really not well established. But what's important to this presentation is that it's a highly cationic molecule that spontaneously forms tetramers and that binds to heparin and to glycosaminoglycans on the vasculature and on hematopoietic cells in the circulation, forming large oligomers. So any theory about that in which you want to relate anti-platelet factor 4 antibodies to HIT or to VITT in the case of HITT, it has to be able to explain several phenomena. One, the prevalence of these antibodies, which is very high after heparin exposure, reaching as many as 25 to 50% of patients who after cath and cabbage. It has to explain the incidence of the prevalence of this disease after receiving different forms of unfractionated heparin, which I'll go into. It has the action of these antibodies has to occur at clinically relevant concentrations of heparin to be significant. And somehow any theory invoking these antibodies has to explain the inordinate incidence of thromboembolism. So let's see how well we can do. In terms of chain length, the risk is about 1% in patients who get unfractionated heparin in therapeutic doses for a week. It's only at 10% of that in patients who get low molecular weight heparin. And it's so infrequent after prophylactic heparin that routine heparin monitoring is not generally used. It's also very heparin concentration dependent. So on the ordinate is a measure of platelet activation. On the abscissa is various amounts of heparin concentration. And so antibodies from a patient with HIT were added to these platelets at various heparin concentrations, and we look for the extent of activation on the ordinate. And badness happens over a very narrow molar ratio of heparin to PF4, which just happens to be the therapeutic concentrations. So what happens at those special concentrations, the ratios of PF4 to heparin? Well, what happens is shown on this electron micrograph from John Weisel. In the middle, on the left column, you see the size of PF4. In the middle, on B, you see the size of the very large complexes that form between heparin and PF4 at those molar ratios. And then if you deviate on either side of those molar ratios in C, you see heterogeneity in the size of the complexes. What you see in the bottom of those antigenic complexes decorated with a monoclonal anti-PF4 heparin antibody. And the arrows are to indicate that there are multiple antibodies bound to these large antigens. And by biophysical approaches, we can see that these complexes are as large as 1 to 2 micron in size, which is enormous for an immune complex. So we've learned more now from the crystallography, the co-crystal structure of platelet factor 4 with heparin. But in order to do these and hit IgG, but in fact, in order to do crystallography, you have to have purified reagents. So I'm going to show you here the crystal structure of platelet factor 4 with the pentamer, fondaparinux, that is the portion of the heparin molecule that binds to antithrombin 3 to exert its anticoagulant effect. And I'll be talking about this monoclonal antibody, which is called KKL, which is an antibody to platelet factor 4 complexes developed by Gal Arapali at Duke. And what I show in this slide is, first of all, that step 1 in this process is that PF4 forms tetramers. Here's one tetramer, and here's another tetramer. And then the second step is these tetramers can share a polysaccharide. So even a 5-sugar polysaccharide like fondaparinux can bind to 2 different PF4 tetramers. The next step is that these antibodies, these HITT antibodies, bind not to an isolated domain, but to multiple tetramers in that complex. So here's a Fab portion of that antibody, and it's binding to, you can see multiple different portions, multiple different monomers within the complex. So this allows these antibodies to bridge one PF4 tetramer with another PF4 tetramer. So this is hard data, this is crystallography. What follows is modeling based upon that information. What I'm proposing on the left is here's a fondaparinux molecule, and here's multiple fondaparinuxes lined up, which would be the case with unfractionated heparin, which is 10 to 40 kilo sugar residues in size. And you can see, if I could keep this stable, that you can see that multiple PF4 molecules can bind now to a single heparin molecule. And these antibodies, which can cross-link various PF4 tetramers, can now bind to these multiple PF4 tetramers aligned along the sugar residue, forming these large immune complexes. So I think that this hypothesis can explain a number of different clinical observations. In the center, this is PF4, these circles here are the tetramers. The red represents unfractionated heparin. And at that approximately 1-to-1 molar ratio of heparin to PF4, you form these large immune complexes. When you, on the right side, if you give huge amounts of heparin like you would during the initiation of bypass, we can see by physical techniques and by laboratory measurements that these complexes break up, and patients can actually tolerate a single large bolus of heparin as long as it's not continued thereafter. On the bottom left, I show in theory, the consequences of low molecular weight heparin, which can bind which can bind PF4, but is much less likely to form these complexes because it's not large enough to bind multiple PF4s. And on the upper left, I show the circumstance of some patients who've been re-exposed to heparin without getting the disease again. And that's because although they may have gotten heparin, they may not be in a situation like bypass where there's huge amounts of platelet activation and platelet factor 4 in their circulation, and therefore they don't form that antigen. So how do these immune complexes cause thrombosis? And the data I'm going to show you support the mechanism that the way this happens is by signaling in platelets through a receptor called FcR gamma 2A, which binds to the Fc portion of IgGs and immune complexes. And there's lots of data for this, but I'm going to show you one supporting piece of information. So mice don't have this receptor on their platelets, so one can invest this in a transgenic way to make their platelets will express this. You can knock out mouse PF4 and invest this mouse with human PF4. You can then mate these animals to get double transgenics. You can inject them with this monoclonal HITT-like antibody and then heparinize them and see what happens. And this slide shows what happens to the platelet count. On the left side, you see that the platelets in the double transgenic animals drop by 80%. In the single transgenic animals, there's no effect. And with the isotype control, there's no effect. So profound thrombocytopenia. In terms of thrombosis, this is the double transgenic mouse getting that anti-heparin PF4 antibody with saline, and this is the lungs of those mice. And compare that to what happens when you when you try to anticoagulate these mice with heparin, and then you can see you get diffuse microthrombi. So the salient features of this disease, thrombocytopenia and thrombosis, relate to the presence of heparin PF4, antibodies to heparin PF4, and the expression of Fc receptors, at least in this murine model. So why then is this such a prothrombotic disease? And this slide summarizes the work of many labs over many, many years. And on the top, you see the effect of the binding of heparin PF4, which here I'm showing here, and I hope you can see my arrow, binding to the surface of platelets. These antibodies bind, they signal through the Fc receptors, and those platelets will then aggregate, they'll adhere to endothelial cells, they'll release procoagulant microparticles. But the same thing happens on the surface of monocytes, neutrophils, and endothelial cells. These PF4 molecules can bind to the glycosaminoglycans on their cell surfaces, also forming an antigen to which these antibodies bind. And then you get activation of Fc receptors or complement, and the monocytes will make tissue factor and release cytokines, the neutrophils will make nets, the endothelium will release tissue factor and release ultra-large VWF. And the net result of all of this is the generation of thrombin, which then back activates each of these processes. So it's no surprise that therapy is based upon interfering with thrombin or with 10A, which precedes the generation of thrombin, to prevent this back activation and amplification steps in the prothrombotic process. So having discussed this pathogenesis, how do we make use of this in the testing for these antibodies, and how, I'm going to move back now to the clinical for a few minutes. This slide shows the need for that I think is one of the best evidences for why it's so important to make a diagnosis in a timely manner. And it comes from a trial of leporudin, which an antithrombin agent that we're not currently using. And in this trial, patients suspected of having HIT, or here it's called heparin-associated thrombocytopenia. Patients were enrolled in the trial. So that was time 0. That was day 1 of being in the trial. But they were not allowed to receive the anticoagulant until the test came back and confirmed the disease. And that took an average of about a day and a half. So in that first day and a half, between disease recognition and affirmation and beginning the anticoagulant, about 5% of those patients already had a new thromboembolism. And you can see that as soon as therapy was begun, the incidence of new thromboembolic complications was reduced. So that first day and a half is really important in trying to establish the diagnosis and in terms of giving proper therapy. So the way we begin to think about the diagnostic probability is we start with what's called the 4T score. I'm not going to go into this in great detail because I think you're probably all familiar with this, and there are apps that you can download that will make these calculations of pretest probability. I'll just say that for the sake of the talk that you get points for thrombocytopenia. In this range, you get points if the platelet count is falling in the proper temporal sequence. You get points for thrombosis, and you get points when there's no alternative explanation for these phenomenon. And you get less points when you have inconsistencies, variation from this optimal presentation. And then you add those points up. And if it's 0 to 3, you consider it to be at low risk and you should continue heparin. And for reasons I'll talk about, you probably should not be ordering a test in this circumstance. And the lab should probably not be doing a test. Now we'll explain why. If you have a score of 7 to 9, you're at the high risk category. And it is appropriate to stop heparin and to begin a non-heparin anticoagulant while you're waiting for the test results. And in between, you have to make a judgment as to what you really think the probability of the disease is, and what you really think is that there are no alternative explanations, and what you really think is the risk of switching from heparin, which can be reversed, to a non-reversible anticoagulant. So these are clinical judgments. This shows the relationship, having that 4T score, this shows the relationship between the titer of antibodies and the heparin PF4 ELISA and the clinical probability of disease shown on the ordinate. And you can see that there's obviously a relationship between titer and disease probability. But if you look across this OD of this probability score of 2, you can see there's a wide range of ELISA results. And if you look vertically here, you can see that there are both high and low scores. So that the same OD can be associated with different probabilities of disease. And I try to explain to our laboratory medicine residents that their world is bounded by this and the square of ambiguity, because nobody's going to call them in the upper right where they're sure they have the disease and the test come back flamingly positive, or if they do a test and it comes back negative in a person who never should have had the test to begin with. So what are the operating characteristics of this assay? The sensitivity is very high. However, the specificity really depends upon the clinical context. So 5% of patients who are getting heparin and dialysis have these antibodies irrespective of their platelet count. 10% of patients after DVTs have these antibodies irrespective of their platelet count. Up to half the patients in the coronary care unit after surgery will have these antibodies, which is an incidence 10-fold higher than the incidence of HITT. So the positive predictive values, but then varies, but the negative predictive value is very high, because there are very few antibodies that have been described that are to other cationic secreted heparin binding dimerizing proteins, but these are extremely rare. So a negative ELISA is a very good clue that this is not the right diagnosis. This is a terribly complicated slide, but I will talk you through the key element because I think it's an important, and it came from a colleague at Penn, Adam Suker. So here on the left, you have the 4T score. Let's say that you're at 0 to 3. No matter what testing you do, the chances of you finding HITT are very low, and the chances of you having a false positive result are very high. If you have a high 4T score, then it's most likely you're going to wind up with a diagnosis of HITT, but the testing helps. But where the testing really helps is when you have this intermediate type of 4T score and you have a some probability of the disease. And you can see that if you look now at this population and look at the range of the optical density, you can get a likelihood ratio, and you can, through Bayesian analysis, you can combine the pretest probability, the likelihood ratio of what ultimately will be diagnosed as having HITT, and you can get a post-test probability. So look at this patient that has a 4T score of 4.5. He's got a roughly 15% chance of the disease. has a positive test, not a borderline test, a positive test. And yet this patient still only has a 15% chance of having this disease. So there are circumstances where you really would like to have the result of a functional assay to help you narrow this down. Now, there are many, many functional assays that are available to test the activity of these antibodies. We use a test in our lab in which normal platelet-rich plasma are pre-incubated with a radioactive molecule, C14 serotonin, that's taken up into the granules of these platelets. We then take plasma from patients with HITT or control that are providing both antibody, but also providing PF4. And then we remove heparin, any heparin that might be in those samples. And in our hands, 10 to 20% of patients who are suspected of having HITT are still getting heparin, measurable heparin. And we remove that heparin, and then we add back therapeutic concentrations of heparin, and we look to see whether or not this causes antibody-dependent, heparin-dependent platelet activation with release of radioactivity. Other labs use aggregation, formation of microparticles, activation markers by flow cytometry. There's pros and cons of each of these assays. What are the operating characteristics of this assay? Well, if you use PRP, it's not as sensitive as if you use washed platelets unless you add back platelet factor 4. The specificity is very high. If you have a strong pretest probability and you have this test, that's HITT. I don't usually say that about tests. So the predictive value is very high, but some of these patients are going to have negative SRAs, and then you're just going to have to go back and rely upon the combination of pretest probability and optical density from the ELISA. So I found it interesting. This is an paper that came out from a group at Penn, not including me, but it's a chart review of 239 patients who have a diagnosis of HITT in the EMR. And 42% of these, 100 of these patients, 42%, it was the test, the diagnosis was incorrect or not confirmed because their 4T score was less than 3 or they had the negative ELISA. And these were adjudicated externally, by the way. 68% of those patients were still getting, for some period of time, an irreversible anticoagulant. And that led to significant incidents of major bleeding. And what I find most intriguing is that when these authors look back at the EMR, 68% of these patients still had a diagnosis of HITT 3 years later. It had never been removed from the chart. Heparin was still being considered to be interdicted, and they were still being potentially exposed to other anticoagulants, and you can see that what the incidence of bleeding was. So I'm not going to spend, I just don't have time to go through, can't go through every clinical scenario and potential treatment options. I recommend looking at the ASH guidelines, which are in Blood Advances. There's the reference. I'm just going to go over in general terms. Risk reduction is to avoid unnecessary exposure to heparin. And I just throw in that question about universal thromboprophylaxis. Use low molecular weight heparin in lieu of unfractionated heparin whenever possible, and monitor platelet counts. When HITT is suspected, I hope you'll agree that the tests are urgent. You should discontinue all exposures to heparin. It is recommended that you avoid or reverse Coumadin because these patients start with a low protein C, and it can drop even further, leading to skin necrosis. What is also true is that patients can get exacerbated, and I can't explain this at all, why patients who are exposed to small amounts of heparin, who have active disease, can have the disease exacerbated or perpetuated. But there are plenty of reports of individuals who have heparin bonded catheters, which is what you see here. Most catheters are heparin bonded. They elute 4 to 10 units of heparin a day. That would seem trivial to me, but you can see this patient had thrombocytopenia on the ordinate, which continued until the catheter was removed. And the same is true for this patient. There are small amounts of heparin in a number of intravenous solutions, hyperalimentation, a number of medications that you administer to patients intravenously could contain small amounts of heparin. And so I just call this HITT by protocol. So the treatment is predicated on the ability to do better than this natural history study. So on the left, you see the cumulative rate of thromboembolic complications over a month after HITT was recognized and heparin was stopped. So can we do better? Well, we treat patients with direct thrombin inhibitors, as you know, our gachaban, bivalirudin, or anti-10 inhibitors, fondaparinux if they're stable and aren't about to have surgery and have reasonable renal function, DOACs if they can take an oral medication. And that works, and we'll talk about how effective that is in a moment. There are patients who are not responding to this and are given IVIG, which blocks platelet activation by occupying these FC receptors. Plasma exchange is used preoperatively in a number of institutions. I don't have experience with this. And epifenamide to block platelet activation, but of course the patients are thrombocytopenic and maybe post-op. There are studies ongoing using desulfated heparin, which has anticoagulant activity but doesn't bind PF4 very well, with immunosuppressants like BTK and SYK inhibitors to try to block neutrophil and monocyte activation. And there's an enzyme called IDES, which has been used to digest IgG antibodies in patients with allograft rejection. It's been shown to block these HITT antibodies in vitro and in animal models. I'm not aware of its use in patients with HIT. So what are the real world outcomes now with all these advanced medications? On the left side is a multi-institutional study authored by Dave Cooter from MGH. On the right are studies coming out of Penn. You can see the incidence, the number of people with HIT and HITT, in other words, thrombocytopenia or thrombocytopenia with thrombosis. And you can see a substantial mortality rate it persists. You can see the amputation rates. You can see the rates of new thromboembolic complications, and surprisingly, the incidence of major bleeding based on ISTH and WHO criteria. So, there are still plenty of patients who are not doing well, even with proper recognition and even with proper intervention. So I'm just going to close the HIT part of this by providing you maybe an alternative way of thinking about management. And this comes from the co-crystal structure of another monoclonal anti-PF4 antibody raised by Galera-Poly. And this antibody binds to PF4 monomers. And I'm showing that on the left side. On the right side, these arrows are meant to indicate that where it binds to monomers is exactly where monomers bind to monomers. And these antibodies prevent monomers from forming tetramers. And these antibodies, we have shown that this antibody will inhibit HIT antibody-induced platelet activation in vitro. And it also works in an animal model. So this is this HIT mouse that has human PF4 and FC receptors. Platelets are fluorescinated. You get a laser injury to the vasculature. The size of the lesion is shown on the left. And then on the right, this is before the injury. On the right, you see the platelet accretion in the injury in the lesion after injury. And you can see that KKO, this HIT antibody, increases the size of platelet deposition, whereas this blocking antibody reduces it, and the magnitude of that reduction is shown on the right. So this is suggesting that if you can block PF4, block tetramer formation, and block immune complex development, there may be either through small molecules or antibody fragments or another mechanism, it may be a rational way of intervening in a disease-specific manner that could be used in conjunction and may reduce the risk of bleeding on anticoagulants. So let me close the HIT portion by asking a couple of questions. How does heparin turn PF4 into an autoantigen in an immunologically normal host? How can we distinguish the anti-PF4 antibodies that don't cause disease from those that do? And how can we develop rational versus reactive downstream thrombin inhibitor type management strategies? So I think these are all issues to be addressed that need to be addressed in the future. So I'll turn now to the second part of my talk. I was asked to talk about vaccine-induced thrombosis. And so the term, the original term that was used by most and continues to be used by most investigators is vaccine-induced thrombosis and thrombocytopenia, or VITT. The CDC and FDA would, for reasons that are obvious, would prefer us to call this thrombosis thrombocytopenia syndrome. But basically we're talking about the same group of individuals. So I'm going to show clinical presentation based upon the largest study that I'm aware of, the largest cohort, which came out of the UK registry and was published in New England Journal last year. The interval after vaccination is a median of 14 days. Thrombosis occurred in almost every one of these patients. And remarkably, 50% of these patients had cerebral venous sagittal thrombosis, sagittal sinus thrombosis, including a high incidence of intracerebral hemorrhage, and another unusual proportion of patients, unusually high proportion of patients, had portal or splanchnic vein thrombosis. Thrombocytopenia is all over the place. There's platelet counts below 10, and there are platelet counts that are over 100,000, but you can see that the mean is. What's remarkable, again, is that the dimers are astronomically high compared to most disorders. And in some patients, the fibrinogen is low as well, suggesting an intravascular coagulation process. So based on that, those features, these authors propose the following criteria. They say that you definitely have this disease if you meet the following 5 criteria. Onset of 5 to 30 days after initial vaccination, or adenoviral vaccination, although they included patients that were outside this range. You have a thrombosis, often at those sites, but not necessarily at those sites, low platelet count, high D dimers, and positive PF4 antibodies. And I want to come back to this because this is an ELISA that measures the wells are coated with PF4 heparin or PF4 polyanions. So I'll come back to that feature in a moment. So having these features makes the diagnosis in their hands definitively, but they do not require a platelet function assay, unlike the German groups, which require that you document a PF4 dependent platelet activation antibody. These authors argue that probably have VIT if you meet 4 of these criteria, and you might have VIT if you hit 3 of these criteria. So this means that there are some patients that will have non-confirmatory serotonin release assays, and even in their hands, 5 to 10% of these patients don't have positive PF4 ELISAs. They were managed by serial imaging because patients could come in with headache and somnolence, and their initial MRI or CT is negative, and then it becomes obvious a day later. Platelet counts may be 150 or more initially, and then drop the day later. And the management is generally with IVIG, presumably to block platelet activation. Some of these patients received corticosteroids for very low platelet counts. Some received plasma exchange, but there was no hard data to support this. And most patients were treated with a non-heparin anticoagulant based upon the presumption that this pathophysiology is similar to HITT. But about a quarter of these patients received heparin. And there was no difference actually in the outcome of these two groups of patients. So the outcomes is that a substantial number of these patients need neurosurgery or thrombectomies. The mortality rate is very high, especially in those that have central nervous system involvement. And it correlates with low platelets and high D dimers. So the US experience was just reported in the Annals last week. You can look this article up by C et al. They looked at VAERS, which is a voluntary reporting of adverse events. They looked through 579,000 reports of adverse events after vaccination, of which they came up with 57 cases that criteria I'll tell you in a moment, 54 after Johnson & Johnson, and 3 after an mRNA vaccine. And so the argument is that the mRNA vaccine data is basically baseline. So tier 1, meaning definite diagnosis, a patient had thrombosis that was CNS or in a large arterial or venous system a week after surgery, in the second week after vaccination with a low platelet count. Tier 2 is if they had a thrombosis at another site or a typical site and had a confirmatory ELISA or SRA. So the criteria here are some overlap, but not identical to the UK criteria. 69% of the patients were women, but it's not clear whether that reflects the vaccinated population or actually represents a preponderance of women involvement in women. 70% of these patients presented with headache, 54 with cerebral venous thrombosis. Most patients had a positive ELISA, but not all. And look at the incidence of negative SRAs. I mean, so of course, these are being done in many different ways in many different institutions. The mortality is somewhat lower, but not much lower than even with recognition of this disease from the initial reports. They made no comments on the difference between anticoagulating these patients with and without heparin. So comparing VITT with HITT, I mean, obviously one's initiated by an adenovirus, one by heparin. The timing is similar, platelet count being low, thrombosis is similar, but not the sites of thrombosis. Sites of thrombosis are very different between HITT and VITT. The D-dimers are much higher in VITT. And the SRA in VITT shows PF4 dependence and heparin independence, whereas in HITT, it shows heparin dependence. And it's also enhanced by putting in PF4, but it's a heparin dependent versus a heparin independent assay that is, one has to explain to try to understand why VITT is different from HITT. So I'm showing you some recent studies that just came out trying to understand the pathophysiology. On the left side is a study that was shows the portions where PF4 binds to the Chadox, the vector that's used for the vaccine, the COVID vaccine, and it binds to what's called the interhexon sites. The hexons are negatively charged, and they can bind to platelet factor 4. In the middle panel, and the next two panels are studies that came from a group in McMaster. And what they did here is they did what's called alanine scanning mutagenesis of these antibodies and platelet factor 4. So they substituted alanines for the existing residue and then asked the question, would HITT antibodies bind and would VITT antibodies bind as you mutate individual amino acids? And in the middle panel, you see where the HITT antibodies bind, and they in blue, and where heparin binds in red. And so they clearly are at different sites. And in fact, the sites that they identified were identical to the site that we found by mutagenesis and by co-crystal. On the right side, you see the complete overlap between the heparin binding site, which is in red, and the binding site in where the antibodies in VITT bind, which is sort of a chocolate color. And so the binding sites of these two antibodies are quite different from each other. So how could this happen? I mean, how could this adenoviral vaccine, first dose, otherwise healthy individual, lead to this terrible outcome? This is a study coming from Greinacher's group, among the original discoverers of this syndrome. And it's very theoretical. It's based upon a combination of in vitro data and murine data. And I just want to run through what he reported and what he found and what his group proposes, which is that when you get an intramuscular injection of the vaccine, some proportion wind up hitting the vasculature. And what's happening, what they propose is that there's some EDTA in the occipient that the vaccine is in, and this increases the permeability of the vessels and allows the virus access to the intravascular space. And then when the platelets, when the virus hits the platelets in the intravascular space, they aggregate, they release platelet factor 4. The spleen takes up this adenoviral PF4 complex. It then educates the immune system and the lymph nodes, and they make antibodies to heparin PF4 complexes, which then go on and do all the things that I talked about with HIT. Now, I mean, the problem is that the problem is that there really is not that much EDTA, and there really is no data yet to show that the virus goes intravascular, and certainly not in concentrations that would allow platelets to be activated and persistent enough to go through this education process. So this is a combination of in vitro data, mouse data, and theory. There's another way of thinking about this disease, which is that maybe the adenovirus is a recall antigen. So in vitro, many microbes have negatively charged surfaces, and when they see platelet factor 4, the platelet factor 4 binds to when platelets are activated. The platelet factor 4 will bind to the surface of activated platelets, and there is in vitro data to show that this promotes phagocytosis, arguing that PF4 and activation of platelets and release of PF4 is part of the innate immune system. And there's also data in mice that if you give if you create sepsis in a mouse with some bacteria, that they will make anti-heparin PF4 polyantibodies. And so the question is whether a subset of these individuals already have these antibodies. And when they see the adenovirus, it's really, it's really a recall antigen, which is just going to re-educate and stimulate this immune response. But I still have a lot of questions about this. Why is this a phenomenon that happens after initial vaccination and not after second or booster shots? There should be an anamnestic response, irrespective of what the pathophysiology is. In a study that was just published in Lancet, only maybe 1 out of 300 or 2 out of 300 cases occurred after were not first exposure vaccination causing disease. Why should there be this predilection for the central nervous system and the mesenteric and portal vein system? This is not characteristic of HITT, and it's not characteristic of DIC. It is characteristic of this so-called disease called autoimmune HIT, where patients just develop that presentation and thrombocytopenia with no heparin exposure and have positive PF4 and serotonin release assays. How you recognize and diagnose that disease is a mystery to me. If VITT antibodies bind to the heparin binding site, how can we diagnose this with a typical ELISA, in which those bindings, the heparin binding site is in PF4 is occupied by heparin on the plate? There have got to be a lot of other antibodies in this disease because this particular binding site is included in the diagnostic assay. And that this also leads to a question: if this is the pathogenic site, wouldn't heparin make sense as therapeutic? Because it would not only be an anticoagulant, but it would compete at the antigen antibody level. Or if heparin was being used in these individuals, because they already have anti-PF4 antibody, would they lead to what's called an epitope spread? And they'll develop not only VITT-like antibodies, but HITT-like antibodies. And do patients who have been vaccinated with adenoviral vectors who educate their immune system, but not enough to cause this disease, are they more likely to develop HITT in the future? So I'm going to stop there, and I'm sure there's a gazillion questions, or I would have a lot of questions. And I just want to acknowledge many people who I've worked with at Penn over 20 somewhat years on this project, especially Morty Pons at CHOP and Garo Pali at Duke and Luba at CHOP and John Weisel at CHOP at Penn as well, and other colleagues on this project. So I will stop here and open it up for questions. And thank you very much for your attention.
Dr. Cines, thank you for that really fascinating presentation. We do have a few questions. First from Dr. Morris, and this is with respect to HITT. Is the PF4 antigen exposed in the ELISA always the same antigen as the one causing the immune reaction clinically?
We don't know that. I'm giving you my answer here is a biased answer. I'm going to give you my opinion. It's an opinion answer. I think that the PF4 that's in the well is very heterogeneous. I think there are monomers. I think there are tetramers. I think there are oligomers of varying size. I think there's a whole array of different antigenic sites that are being exposed or not exposed in the ELISA. And I think that's why it picks up so many theoretically unpathogenic antibodies, but it also picks up pathogenic antibodies. So at least some of the PF4 is the epitopes that make a difference are exposed in a subset of the PF4 in a subset of the wells that we use.
Thank you. And a few more questions and comments from Dr. Morris. We previously used the heparin-induced platelet aggregation test, but switched to the serotonin release assay. Does one test have an advantage over another?
Oh, I think they're probably the same. I think the big decision that you have to make is whether you're going to use platelet-rich plasma or wash platelets. The wash platelet assay is more difficult to do, more time-consuming, but is reported to be significantly more sensitive than using platelet-rich plasma. However, recent studies would indicate for a number of groups that if you supplement platelet-rich plasma with PF4, you can get sensitivity and specificity that's about the same as the washed platelet assay. I'm not aware of a difference between aggregation and radioactivity in terms of clinical significance.
Then a comment from Dr. Morris: we performed a meta-analysis of all the unfractionated heparin versus low molecular weight heparin randomized controlled trials and did not find a difference in HITT between the two treatments. Perhaps the high doses required for treatment counterbalances the issue of the long versus short chains.
Well, I'd love to. If that's what you found, that's what you found. So what I'd really like to know are all the details of, what the underlying disorders were and the duration of exposure and et cetera, et cetera. So I welcome that information. I will store it and look forward to its publication.
And then a final question from Dr. Morris: is the VITT binding site on PF4 related to the pentasaccharide region?
Yes, based on that study in Nature that came out of the McMaster group that was published earlier this year, it's identical in their hands. The mutations that prevent heparin binding, which are the same ones that prevent antibody binding. So these are not my studies, but that's the only published data. I don't think it explains everything. I have difficulty because I do think some of those sites are occluded, and yet the ELISA is positive. So I'm wondering, are the other antibodies just an epiphenomenon and used to make a diagnosis, and the pathogenic antibodies are the ones that are hidden? I don't know. I need more data to be confident that that's the pathogenic site.
Excellent. And from Dr. Insel: thanks for the excellent talk. Is there a feature, perhaps a gene, in the relatively rare heparin-treated patients who have HITT versus all the other patients treated with heparin?
Well, there have been a lot of studies looking for predispositions, and the only thing that sort of stands out in some studies but not others is a polymorphism at the 131 position in SCR2A, where there's an arginine histidine, and one or the other is more sensitive to the HITT antibodies. It's not significant enough that we pre-test patients. It's not routine medical, and it's not as if you have the right mutation, you won't get hit, or et cetera, et cetera. I mean, it's a small statistical difference. It's been confirmed in transgenic mice that express these polymorphisms at that position. But no, what's remarkable about HITT and VITT is that, especially VITT, I mean, these patients are healthy, and prothrombotic risks have been looked at in retrospect by a number of groups, and so far has not been identified.
Dr. Shatil?
Yes, Doug, thank you for that wonderful talk. This question relates to the difference in frequencies between the adenovirus-based vaccines and the mRNA vaccines in VITT, which is probably baseline for the mRNA vaccines, and clearly higher for the adenovirus-based vaccine. So the issue is, what are the components of the adenovirus-based vaccines that you think might be particularly problematic? You have virus, you have the host cell components, you have EDTA, as you mentioned in your talk. And is there any way to try to tease this out? Because does this mean that adenovirus-based vaccines are not going to be used in the future because of this problem? Or is there a way to tease it out?
So that's a great question. And as you can imagine, there are a number of groups that are trying to look at different adenoviruses and see whether or not there's a simple strain dependent. You can use a different strain. The surface of the, as I showed you in that that study from Baker, there's a lot of negative regions, I mean, mostly between the hexons, but not exclusively, where PF4 can bind. And if that's the case, if low affinity binding to many sites on a component of the adenovirus that is shared among all adenoviruses, if that's what's responsible, then yes, it's going to be, if you're going to give 100,000 people another adenoviral vector, you would anticipate the same type of response. But I can tell you that the pharmaceutical companies are working very hard on trying to identify what it is about the adenovirus and whether it can be modified and still be useful as a vaccine. I hesitate to try to do that myself. We're not a virology lab.
Thank you. A related question from Dr. Rubin. The AstraZeneca vaccine uses an adenovirus that is not associated with human infection. Are there any instances of human-associated adenoviruses inducing anti-PF4 antibodies?
So I'm not aware of this, but what I showed you a slide on E. coli, inducing these antibodies. And the question is whether or not prior exposure to adenoviruses, could lead to sensitization. But then, one would think that the vaccine wouldn't work. You'd have these antibodies, the adenoviral antibodies, you'd get an anamnestic response that would neutralize your vaccine. And that isn't the case. So I don't know. I mean, I don't know the answer to that question.
Thank you, Dr. Cines. Last chance for any questions for Dr. Cines.
Okay.
Thank you again for that really thought-provoking presentation. We're so grateful to you for presenting the Ranney lecture, and we want to thank you for speaking to us this morning. I want to thank all of our participants and encourage you to please join us for Department of Medicine Grand Rounds next Wednesday morning. Thank you.
Thanks again for the invitation. Okay, bye now.
Have a great day.
Thanks.